Hi guys, just give me 1 second. I'll just upload this. I want to discuss uh, endometrial cancer and partogram. After that, I have a lot of other work to do, and then some other work to do, and then I will something. Okay. So we have endometrial carcinoma. What are we going to write? We're going to write risk factors. First, we're going to start with this causes of perimenopausal bleeding. And causes of perimenopausal bleeding, carcinoma cervix, endometrial carcinoma, endometrial hyperplasia. Then very important in uterus, we have senile endometritis, atrophic endometritis, atrophic endometrium. Then cervix, polyp, cervicitis, decubitus ulcer. cervix polyp and subisata and vagina atrophic senile hormone replacement therapy and 3 hormone secreting tumors Brenner's theca granulosa done. Postmenopausal this one causes. Then we go for incidence 5 to 7% of all carcinoma. It's more common in postmenopausal 55 onwards, and perimenopause also some cases are seen. Risk factors most important: long unopposed estrogen that increases to 10 to 15 times, Lynch syndrome 10 times, estrogen secreting tumors, higher income, old age, white race, nulliparity, menstrual irregularity, PCOS, early menarche, and something called cancer syndrome. That is obesity, hypertension, diabetes, and endometrial carcinoma. Types we have two: estrogen dependent, estrogen independent. Estrogen dependent is the most common type. It's a well differentiated, good prognosis. Undifferentiated is because of P53 mutation in senile endometrium, atrophic endometrium. A poor prognosis, and it is usually papillary serous or clear cell carcinoma type. Histologically, we have most common adenocarcinoma. Then we have adenosquamous cell carcinoma, and third is papillary serous cell carcinoma. It's in type 2. Spread is direct, tubal, hematogenous, and lymphatic. In lymphatic from fundus, it can go to paraaortic, it can go tubal, vaginal, it can go into parametrial, and it can go into pelvic lymph nodes, and via round ligament can go to inguinal lymph node. What is the clinical features? Postmenopausal bleeding, spotting, uh, bleeding, intermenstrual bleeding, offensive white discharge in case of like a big thing, big mass obstructing this one causing pyometra. Cervical atrophy of the uterus can be normal. This one, and per vaginal examination, cervix can be normal. Diagnosis most important: Pap smear. Endometrial biopsy is very sensitive using Pippel's DNC or fractional curettage. Fractional curettage is Pap smear, endocervical curettage, and cervical curettage. Endometrial curettage and cervical curettage. Then we have transvaginal sonography, wherein the endometrium, if it is more than 4 in a postmenopausal lady or a perimenopausal more than 12 we should suspect endometrial carcinoma. Immediately we should do endometrial biopsy. In Doppler, we have increased this one, and the gold standard hysteroscopy with biopsy. Other than this, we have CT for metastasis and MRI for checking for myometrial expansion. Then we have staging. Stage 1 is to the this one body. Stage 2 is to the cervix. Stage 3 is for the local. Stage 3 is to the adnexus. Stage 3 is serosa vaginal lymph node. Okay, stage 4 is to the adjoining structure. So stage 1, there are 3 grades also: grade 1, grade 2, grade 3. Grade 1 is uh, well differentiated glandular and shows the atypia. 2 is some solid structure. 3 is lot of solid structure, no architecture, and massive proliferation. Now in stage 1, we have this one, stage 1A less than 50%, stage 2 more than 50%. Stage 2 is cervical carcinoma, is invaginated the cervical stroma. Stage 3 serosa, vagina, and lymph node. Serosa is stage 3A. Stage 3B is vaginal involvement. Stage vaginal parametrial involvement. Stage 3C is lymph node involvement. In that, C1 is pelvic node involvement. C2 is pelvic node, paraaortic plus or minus pelvic lymph node involvement. Then stage 4 carcinoma, we have bowel and bladder involvement is A, and B is distance metastasis to the or like inguinal lymph nodes. So this finishes endometrial carcinoma diagnosis, staging. Yeah, treatment. Let's write this. Stage 1A, G1, we have total abdominal hysterectomy plus bilateral salpingo-oophorectomy. This is uh, what is it called? Yeah, extrafacial hysterectomy with this one, type 1. Okay. First we do staging. First staging is done in the table, on the table. So we have intra-abdominal exploration, and we have peritoneal washing. After this, after staging is completed, we're going for this one, stage 1A G1. We're going to either go for LNG, intrauterine device in case it's a non-surgical, or best is total abdominal hysterectomy, bilateral salpingo-oophorectomy, type 1 extrafacial type. Okay. Then stage 1A grade 2 grade 3, stage 2, stage 1A grade 2 grade 3. We go for stage 1A grade 2 grade 3 and stage 1B grade 1 grade 2. We go for surgery, brachytherapy using vaginal colpostat. Okay, that's done. So grade 1A G1, then grade 1 rest, grade 2 everything other than grade 3. Now grade 3 we go for external beam radiation also. Grade 2 also we give external beam radiation. Then grade 3, grade 4 we give chemotherapy as well, and we also give progesterone. Now progesterone, how much do we give? Radiotherapy, how much we give? 16 grays we give for 6 weeks using vaginal colpostat, or we give external beam radiation. Then in non-endometrial type of carcinoma, we also do omentectomy. And chemotherapy, we give cisplatin, carboplatin, we give paclitaxel, doxorubicin. In progesterone, 200 milligram daily or 1 gram weekly or 1 gram IV, IM. Or we give LNG primary treatment in case of non-surgically not possible patient in stage 1A, grade 1. Follow up 3 monthly, 6 monthly, then yearly. Okay, what and all we do? History, clinical features. We do endometrial biopsy. Sometimes, most of the time, CT, MRI, mammogram, and carcinoma. CA 125. Stage 4, stage 3, stage 4 prognosis 20%. Stage 1 prognosis 75-60%. Okay. What is the prevention? Always combine it with progesterone in HRT. Fully treat PCOS. Uh, Combined oral contraceptive pills helps in obese patients. LNG IU6 helps in simple hyperplasia. And tamoxifen do a regular endometrial. So what is important prognosis is staging, grading, metastasis, lymph node involvement, all that. Fractional curettage. Yeah, what is fractional curettage? Fractional curettage is we do pap smear, modified fractional curettage, pap smear, endometrial curettage, and this one, cervical curettage. Okay. Now, what is the procedure of doing this? First, we do cervical curettage, then we do dilatation, and then we do endometrial curettage. The fundus, anterior, posterior, all of them separately stored and put in this one sample, and then we use a polyp forceps in case a polyp was missed out during endometrial biopsy, and then we put it in the container and we send it. What are the indications? We have diagnostic indications such as AUB evaluation, endometrial carcinoma, postmenopausal bleeding, endometrial TB, pathological amenorrhea, infertility. Okay. Then in dilatation curettage, you can also add polyp, incomplete abortion, and removal of IUD. Complications can dilate. Yeah, first you should put uterine sound here. Curettage, then we do put uterine dilatation, you put uterine sound. Yeah, that I forgot. Sussex perforation, you stop the procedure. So that's it about curettage, this one, and okay. Now, partogram. What is partogram? Partogram is a graphical recording of the key events of labor on a single sheet of paper. Key events of labor, single sheet of paper. We have some history, Castles, Crichton, WHO. Okay, what are this one? Fetal heart rate, amniotic fluid, molding. After that, we have three things: fetal heart rate, amniotic fluid, molding. Descent, cervical, this one, number of contractions per 10 minutes, descent of head, and cervical dilatation. This is on alert and action line. And then we have drugs, oxytocin, temperature, BP, pulse, and urine. Okay, that is for my mother's well-being. We start marking at 4 centimeter dilatation. 1 square is equal to 30 minutes. Differentiating latent phase from false labor is important. Active phase, okay. Amniotic fluid we write as absent fluid, blood stained, meconium stained, membranes ruptured. Ruptured will be ruptured and clear liquid is C, and I is intact. Intact, clear, absent, meconium stained, all that. Fetal heart rate every 30 minutes, you have to check for 1 full minute. 110 to 160 is normal. Molding, we have grade 0, no bones are felt. Grade 1, it's felt and uh, felt but not overlapping, just touching. Grade 2, overlapping but easily separatable. And grade 3 is not separatable. Okay. Excessive molding can mean cephalopelvic disproportion. Plotting the line, we have cervicograph, cervical dilatation has started from 4 centimeter and we expect it to be 1 centimeter per and primary gravida. Okay. Uh, Contractions, dot, scratch, this one, up to 20, 40 and greater than 40. Dots, crosshatch, darkened. Oxytocin augmentation, drugs given, BP recorded. Advantages, it's good documentation for any kind of transfer, progress of labor, fetal distress, interventions, medical legal processes, abnormal labor. We have protracted labor, arrested labor, primary dysfunction. Okay, I think partogram will continue in some other class. Okay, this much is good. Very good, actually. Okay, bye.